Hi, my name's Lisa Giddings. I want to talk to you today about a few pediatric skin conditions. I have 5 rashes that I'm going to cover, and then at the end I'll talk about 3 autoimmune diseases which also present with some form of a rash. The first condition is impetigo. It's a bacterial infection which is often infected with Staph aureus and Gram A strep. Rarely it can also be infected with MRSA. Most frequently it's found in those that are 2 to 5 years old. It may or may not be bullous with papules, vesicles, and/or pustules that quickly break down to form a golden crust and typically are seen on the face or the extremities. Differential diagnoses include bullous impetigo, non-bullous impetigo, and eczema. A culture of the exudate should be done to determine the infective organism, and that organism is then treated with the appropriate antibiotic. For 1 to 3 small lesions, consider topical that addresses the organisms identified. And for extensive lesions, consider oral antibiotics appropriate to the cultural growth. Cephalexin for Staph aureus, Bactrim for Group A strep or MRSA. Oral antibiotics for 7 days. Educate parents that washing gently and finishing the course of antibiotics should resolve the problem. Patients should see improvements within a few days and can return to school after 24 hours of antimicrobial treatment. If it clears up, no need to return to the office, just practice good hand washing. Wash thoroughly any cuts or scrapes of the skin. Avoid touching the skin of others if it appears infected or broken. Wash bed linens and bath linens in hot water. Use a high heat on dryer. There's no need to refer to a dermatology unless the eruptions are refractory to antimicrobial treatment designated by the local antibiogram. Discontinuing antibiotics prior to complete resolution of the disease may result in recurrence or spread. 3 red flags to consider are number 1, secondary cellulitis, which may occur if there are open wounds within or surrounding the affected areas of the skin. Number 2, one type of bacteria that causes impetigo can also affect kidney function, so any signs of kidney involvement like dark urine, decreased urine output, CVA tenderness. And number 3, scarring. Scarring can be traumatic for children, so encourage parents to keep the area protected so that the children can avoid scratching it. Next up is ringworm or dermatophyte tinea. It is caused by fungus, which subsists on the keratin in hair, skin, and nails. Fungus can be passed from one human to another. It can also be passed by a dog or a cat. A diagnosis is typically based on clinical appearance, as it is a circular lesion or a group of circular lesions with the appearance of an itchy red patch central of the central skin. To confirm the diagnosis, a KOH test can be performed. Differential diagnosis for ringworm includes subacute cutaneous lupus erythematosus. It often manifests as annular or polycyclic erythematous scaly plaques on sun-exposed skin. Also, granuloma annular, which is a benign inflammatory condition that classically presents with 1 or more erythematous or violaceous annular plaques on the extremities. Unlike ringworm, scales are absent. Other disorders, such as nummular eczema, psoriasis, and pityriasis rosea, may be exhibited scaling plaques that resemble dermatophyte tinea. A red flag symptom might be erythema and central clearing, because that could indicate Lyme's disease or the bullseye rash of Lyme's disease. Topical antifungal creams are generally good for getting rid of the fungus, but more extensive or widespread lesions may need oral antifungals. Clotrimazole cream 1% applied twice daily for at least 3 weeks or until clinical resolution is recommended. For infections refractory to topical medications or those covering a greater than a small area, oral terbinafine 6.2 milligrams per kilogram daily up to 250 milligrams a day for 1 to 2 weeks, or fluconazole 6 milligrams per kilogram once weekly for 2 to 4 weeks. To prevent recurrence, do not share clothing with others, wear protective footwear when at a public pool or park, avoid tight-fitting clothing, and wash thoroughly with soap and water after any sport requiring skin-to-skin contact. Take pets who appear to have an itch that is affecting their hair growth in one patchy area to the veterinarian's office. If one person in the household appears to have ringworm, have your provider check everybody in the household. Here we have Fifth disease, or erythema infectiosum, which is a virus caused by the parvovirus B19. It is sometimes referred to as slap cheek because of its appearance. It can range from a mild febrile illness to a very serious aplastic crisis. Another concerning symptom is joint arthralgia, which may affect up to 10% of patients. This typically is symmetrical and may last up to 3 weeks. In more serious cases, the arthralgia becomes recurring but does not cause joint destruction. Transient aplastic crisis is rare in typical children, but is common among those with sickle cell. TAC can lead to severe anemia and all related complications. Laboratory analysis often demonstrates a decrease in hemoglobin concentration secondary to interruption of erythropoiesis. The anemia is often sufficiently severe to require transfusion until the patient's immune system response eliminates the infection and red cell production returns. While TAC usually only affects red cells, white cells and platelet counts may also decrease. A bone marrow biopsy is usually remarkable for severe aplasia of the red cell line. Differential diagnosis includes other infectious rashes like roseola, rubella, measles, enterovirus infection, and group A strep. The quality and distribution of the skin eruptions, as well as vaccination history and the presence of other symptoms, can often be used to distinguish between these infections. If joint pain develops, ibuprofen is the medication of choice for children. Parent education involves good hand washing often with plenty of soap and water, and using alcoholic hand rub as well, and teach your children to do the same. Children as well as adults should never share food and drinks with other people. Here you see hand, foot, and mouth disease. It's a syndrome characterized by a mucous membranous rash and a maculopapular or vesicular rash of the hands and feet, and possibly other locations. Hand, foot, and mouth disease is one of the most recognizable viral rashes in children and adults. It was first described in a summer outbreak that occurred in Toronto, Canada in 1957, caused by the Coxsackie virus A16. Now we know there are at least 15 other enteroviruses that may have the same effect, most commonly Coxsackie virus A. Hand, foot, and mouth disease is an infection that causes sores to form in the mouth and on the hands, feet, buttocks, and sometimes the genitals, while a related infection causes the herpangina, or the sores in the mouth. Both infections most often affect children, but adults can get them too. It usually goes away on its own within 2 to 3 days. Treatment available is for symptomatic relief only. Differential diagnosis includes canker sores and herpes simplex virus 1, insect bites, eczema, and chickenpox. Testing can be done on the vesicle scrapings. A PCR for enterovirus, and HSV can help rule this out, but it's rarely necessary. Red flag symptoms rarely occur, but include signs of neuralgia, respiratory complications, or circulatory complications, which can lead to death. Hospitalization is warranted in these cases, but it's, like I said, extremely rare. A referral to a specialist related to the actual red flag symptom will be needed during hospitalization. Otherwise, a referral is unnecessary. It typically resolves in 7 to 10 days with symptomatic care only, with resolution of the fever in 2 to 4 days on average. The throat lesions can usually resolve in 3 to 10 days. Because it is summertime and most providers will see this particular contact dermatitis in the summer, I thought it might be good to include poison ivy. This rash is caused by the poison ivy plant, poison oak, and poison sumac in our area, but it's also the same liquid that's found in the ginkgo fruit tree and the peel of a mango. The leaves are typically green but can turn brown or even red and continue to have the poisonous oils in them even when they're dyed. It happens due to some sort of contact either with the plant itself or the oils of the plant, which may get on clothing or the fur of animals and then is transmitted to the person who gets it. It can actually travel through the air too when you burn the leaves, so you have to be careful not to be around when they're burning poison ivy if they know what it is. Contact typically presents an intense pruritus and erythema. Many will develop papules and plaques, vesicles, and or bulli, often arranged in characteristic linear or streak-like configurations where a portion of the plant has made contact with the skin. Red flag symptoms that may require an ER visit are a rash near the eyes or genitals, signs of infection such as increased swelling, tenderness, redness, pain, pus, or a fever of 105 degrees or higher, or symptoms that don't improve or that get worse after 2 to 3 days of self-care. Differential diagnoses include other types of contact dermatitis, but typically the patient knows that they've come into contact with something that irritated their skin. Symptoms of itching begin as early as 4 hours after contact and may last up to 14 days. And there may be new spreading up to 21 days if not properly cared for. Left untreated, it will usually disappear on its own in a few weeks, but may be treated with over-the-counter calamine lotion or Burrows solution. Topical antihistamines, anesthetics containing benzocaine, and antibiotics containing neomycin or bacitracin should be avoided due to their own allergenic potential. Patients with severe dermatitis, particularly involving the face or genital region, may require systemic corticosteroids. Prevention by avoidance is the best protection, and intense washing with plenty of soap and water, any body part or clothing which may have come in contact with the offending plant is recommended. I'm going to very quickly mention 3 autoimmune diseases often seen in children and talk a little bit about what you'll see with them, so that if you see the rash, it might indicate what's going on when you hear the other signs and symptoms. The exact cause of type 1 diabetes is unknown, but in most people with type 1 diabetes, the body's immune system, which normally fights harmful bacteria and viruses, mistakenly destroys insulin-producing cells in the pancreas. Genetics and environmental factors appear to play a role in the process, but you should be aware that family history is important. Anyone with a parent or sibling with type 1 diabetes has an increased risk of developing the condition. Genetic susceptibility is possible, and race is a factor. In the United States, type 1 diabetes is more common among non-Hispanic white children than other races. The rash typically seen is acanthosis nigricans. It is the most common skin finding in children with diabetes mellitus 1. It's a hyperpigmentation, velvety thickening of the skin folds, and it presents predominantly in the neck, axilla, and groin areas. Other symptoms that may accompany it are increased thirst and frequent urination due to excess sugar building up in the bloodstream, pulling fluid from the tissue. Extreme hunger. Without enough insulin to move sugar into the cells, the muscles and organs lack energy, and this causes an intense hunger. Weight loss, fatigue, lack of sugar causes fatigue, irritability or behavioral changes, fruity smelling breath, burning fat instead of sugar produces ketones that cause that fruity odor to the breath, blurred vision, yeast infections. Girls with type 1 diabetes may have genital yeast infections, and babies develop diaper rashes caused by yeast. So if a child develops any of these, they should see their provider and will likely be referred to an endocrinologist, at least initially, to begin the process. Juvenile idiopathic arthritis occurs when the body's immune system attacks its own cells and tissues. It's not known why this happens, but both heredity and environment seem to play a role. Certain gene mutations make a person more susceptible to environmental factors such as viruses that may trigger the disease. Signs and symptoms include pain or limping, especially first thing in the morning. Swelling of the joints is common, but it's often noticed in larger joints such as the knees. Stiffness, as the child may appear clumsier than usual, particularly in the morning or after naps, and fever, swollen lymph nodes, and a rash. And in some cases, the fever will be quite high. The swollen lymph nodes and the rash on the trunk will be evident. You might notice it also on eyelids or knuckles, and it may appear worse in the evenings. So treatments include helping the child maintain a normal level of physical and social activity. To accomplish this, a combination of strategies to relieve pain and swelling, maintain full movement and strength, and prevent complications is in order. Medications that may be used are nonsteroidal anti-inflammatories such as ibuprofen or naproxen, disease-modifying anti-rheumatics drugs, and that they are the most common one in children is methotrexate or Trexall. Side effects of methotrexate may include nausea and liver problems. And then the other one is biological agents, which are a newer class of drugs, including tumor necrosis factor blockers, and those are Enbrel and Humira. Those medications can help reduce systematic inflammation and prevent joint damage. Other biologic agents work to suppress the immune system, including Orencia and Rituxan. Corticosteroids may also be used to control symptoms until another medication is capable of taking effect. All of these medications can interfere with normal growth and increase susceptibility to infection, so they generally should be used for the shortest possible duration. And finally, we have irritable bowel disorders, and that includes both Crohn's and IBS. They're both thought to be autoimmune disorders. About 15% of children with IBD will have a painful skin rash called erythema nodosum, pyoderma, or sweet syndrome. Several other skin disorders have been associated with IBD, including psoriasis, vitiligo, acne, and hives. Be on the lookout for any unusual changes in these skin disorders that might indicate IBS or Crohn's. Symptoms that can trigger the problem are food, as true fruit allergies rarely cause IBS. Many people have worse IBS symptoms when they eat or drink certain foods or beverages, including wheat, dairy, citrus, fruit, beans, cabbage, milk, and carbonated beverages. Another trigger is stress. Many children with IBS experience worse or more frequent signs during periods of increased stress, and hormones. So females are affected twice as frequently as males, which may be have something to do with the fact of female hormones changing throughout various times in our life. Treatments include aminosalicylates. They're aspirin-like medications that decrease inflammation in the intestine wall itself. Immunomodulators, which is a medication used to treat Crohn's and ulcerative colitis by decreasing immune system activity. Biologics are medications used with IBD that do not respond to other medications and when other medications cause side effects. Or if your child has complications of Crohn's or ulcerative colitis, such as refractory disease or fistulas. They may also decrease the number of immune system cells in the body, and some examples of these medications are Remicade, Humira, and Cimzia. These medications are used to reduce inflammation during a flare and to relieve diarrhea, rectal bleeding, fever, and pain in both forms of IBD. They can also relieve systemic symptoms like joint pain and skin and eye lesions in some patients. That's it for now. If you look below, you'll find a link to a little game to test your ability to recognize certain common skin rashes. And if you follow that on down, you'll see just a little recap of the 5 skin rashes that I talked about initially. Thank you. Have a good day.